Hi, everyone, and welcome to Your Need to Know. I'm your host, Jody Lyons, and today I'm here with Dr. Sasan Hassassian, who's an affiliated physician with National Spine and Pain. I'm so glad you're here today. Thanks for coming.
Thank you for having me.
So, today we're going to talk about why people are in pain and things you can do about it. But first, I want to talk about you, and I want people to get to know you a little better.
Of course.
So I always ask this question, and it usually embarrasses doctors. Why did you become a doctor?
Well, the question is when probably I decided to become a doctor.
That's a great question.
Because early in high school, the two things I was thinking about, one was becoming an engineer, and also in the top two position was becoming a pilot.
Wow.
Because those were the things that I was drawn to. But what happened was when I took my first biology course, I saw something that I couldn't see in mathematics, and I was good at mathematics and I was good at other sciences, but there was something about dealing with live organisms, and then later on I kind of got exposed to situations where I saw that there is an application to this part that you can actually make a change using that biological equations, if you will, to make a difference in somebody's life. And that was totally fascinating to me. And the more I read about it, the more I did independent reading, and I got drawn to it. And that's kind of where I ended up because I didn't see medicine as just science. I saw the ultimate application of science applied to human beings.
That's terrific.
So that's how I got drawn to it.
So your mathematical brain then turned into the math and the biology and the science of treating humans.
Absolutely.
That's pretty cool. I like that. So one of the reasons you're here is because I wanted us to be able to address a lot of misperceptions about pain. I hear this all the time from older adults I work with, which is, my back hurts, and I don't want to do anything about it because I'm sure they're just going to fillet me like a fish and give me spine surgery. So let's talk for a little bit about what pain is, and I'd like to address some of the common misperceptions that we have, because a lot of my clients who tend to be older adults say things like, I have pain in my back, and the stereotypical person who's folded over like this, but they're afraid of going to a pain doctor because they think that the first thing you're going to do is fillet them like a fish and cut their spine out.
Correct.
So can you first start and tell me what pain is, and then we can move into how you approach it? What would it be like if I go to you for a first-time appointment?
You hit it on the nail as far as what pain is, because even amongst the community of physicians, there's still a little bit of a disconnect as to how to define pain. And I'm not talking about scientific way of describing it, because there are definitions for it. For most people, even for physicians, pain is a sign or a symptom. Basically, there was an injury or there was an insult to a part of the body, and basically the natural response to the nervous system is you perceive that as discomfort or something noxious. However, there are situations, and more, where in elderly or in a bunch of other situations where pain is not the symptom but is the disease.
Oh, interesting.
And you have to look at it in terms of the disease, not a symptom. And
tell me more about this. That's like a flipping things on the head.
Absolutely.
Okay.
So let's talk about an example. An example is, say somebody falls down and they break their hip and they have acute pain because of fracture of the hip. That's a sign and a symptom. But then let's think about a scenario where it's not just a sign. Let's say someone had an operation on the back, and this can happen, unfortunately, even in the best of hands, and patients develop scar tissue around the nerve roots as a result of the surgery. And then this constant irritation of the nerve roots causes an overstimulation and activity of the impulses going to the brain. So even if there is no direct problem as far as the bony structures and placement of the screw and all the other surgical techniques are concerned, this constant overstimulation basically revs up a lot of centers in the brain. We call it central pain syndrome. And that is the disease process.
So central pain syndrome is real, and you don't have to necessarily say it was a bad hip surgery. It could simply be scar tissue is causing the central pain syndrome.
A lot of times, I'll give you an example where there is no definite area. Let's talk about an amputation. So somebody had an amputation, either surgically or through a traumatic experience. But then they can feel, for example, the ankle or the toe, whereas there is no limb below the knee. There is no nerve there, there is no foot there, but they get the sensation we call phantom sensation. Sometimes they actually feel pain in that area, we call it phantom limb pain. So this is an example of a disease state of pain, not a sign and symptom.
That is amazing. I have to say, I did not know that, and I'm sure a lot of other people didn't know that, so that you could look at the pain itself is the problem, not look for some other cause, like is there a structural problem with your back or something like that. It is the pain itself is the disease that would need to be treated.
Absolutely, and then the pain itself is how you define it. So this is what I used to teach when I was in academics. So pain is not necessarily a physical phenomenon. It's rather complicated and complex because there is an emotional component to it too, which turns into suffering. So you have to realize how complex the situation is, because at the end of the day, we have so many tools in our toolbox. So you have to pick the right tool for the job.
So let's talk a little bit about what kind of tools are in your toolbox, because I know it's not all a hammer and the symptoms and diseases aren't always just a nail. So what sort of things do you have?
So again, before talking about the tools, let's talk about defining the problem.
That's even better.
So because this is the issue I see all around, and I've been doing this for a long time. A lot of times I get referral and they say, treat the patient for back pain or treat the patient for neck pain. Again, neck pain, back pain is a presentation, a symptom. It's not a diagnosis. No one says, I have sore throat, give it antibiotic. You have to know what's causing it. Is it a bacterial issue? Did they drink some hot liquid? They have a burn in there? Is it a viral issue? Is it a tumor growing there? So if you don't define the question properly, then you can never have the proper answer.
So the question would really then be, my back hurts.
Why?
And you then say why and what's the cause.
And that's one of the things where the pain specialists come in, because we need to provide to the patient and to the referring providers that why this is happening. What is the reason? What could be going on? Because based on that, then we can go back to our tools and pick the right tool. Because if you said it early on in my career, if you can't think about a diagnosis, you can never diagnose it, and you can never treat it.
I like that.
So the back pain or any pain needs to be defined as to what's causing it. Now, once it's defined, then you go back to your toolbox as to what it is. Now, on the back pain itself, you can have acute pain or chronic pain. Now, acute pain, typically we don't see that as much, but the sprains, and somebody was a weekend warrior that did some muscle pull.
I was just going to say, you see them all on Monday morning,
So things of that nature. So you don't need to pull out the big guns and do a complicated work for this. But a lot of times, I guess for the audience here, we're talking about more of the later stages where it's been there for a long time, or some months at least. So it's becoming a chronic issue. So that's when we need to figure out what's going on.
So should they go to you for both? I mean, should a patient, so a patient can say to you, this is a sudden pain, meaning acute pain, or chronic pain, and they can still show up to a pain specialist and get an answer.
Absolutely, because a lot of times we see patients either through themselves self-referring or go to a primary doctor and they say I have back pain, and automatically they get pushed over to an orthopedic surgery program.
Yes, yes.
And I really have a lot of admiration for my orthopedic colleagues, but most of the stuff as a surgeon, they offer surgical solutions.
Right.
And that's what they got trained for. So, and that's not necessarily the first step. You have to do A before B before C. So surgical options or maximally invasive options should be at the end of the line, not at the beginning of the line.
Well, I think
And
you just raised a really good point. I'm sorry to interrupt,
okay.
but I want to make sure I'm understanding this. People should not be afraid of seeing a pain specialist because it's not that the first thing out of your mouth is going to be you need surgery.
Absolutely, because
Okay.
most people, if not all people who come to our practice or to my practice, are primarily for two reasons. Number one is to find a solution that as least invasive as possible.
That's important
And
to hear.
number
Okay.
two, find a solution that make them less dependent on medications.
Well, that's also very important with people who are afraid of taking pain pills because of the opioid crisis,
Absolutely.
and people who are afraid of taking pain pills because it affects cognition, and people who are afraid of surgery.
Correct.
So what you're saying is that they shouldn't be jumping to conclusions. They should go see somebody like you first to find out what's really happening, because pain is a disease itself. And then they can move on to what the interventions might be. So they shouldn't be jumping to conclusions and panicking and avoiding going to you because of that. Is that a safe statement?
Absolutely. For
Okay.
acute pain, for most part, there are very least of the invasive options and non-invasive options. And there are a whole host of things going back to that scenario of toolbox. Now, as you go through later stages and you have gone through A and B, then there are some procedures that can be implemented. But again, the focus is on minimally invasive first. And by doing that, again, what are the goals? The goals are twofold. One, improve quality of life. And number two, improve functional status. So
That
it's
makes a
not
lot of
just I'm
sense.
decreasing the pain, I'm decreasing the pain because I can do more. And it could be very different for different folks. Like say you have an 80-year-old who was just was able to walk 10 or 15 feet without having pain.
Right.
Now you try to make that 50 feet or 100 feet or 200 feet. Somebody who could go and just sit for like 10 minutes and they had to get up because they had pain and they couldn't go to the movie theater with their grandchildren.
Yep.
Now you can make it 2 to 3 hours. So it's not just decreasing the pain by itself. Yes, that's great. That's quality of life. But then on the back end, you want the functional status to improve as well.
That's wonderful. And so right now we need to take a break. I want you to remember where we were, which was improving functional status and things like that. When we come back, we're going to talk about what would happen at an appointment with you. So what can a patient expect?
Absolutely.
Everybody will be right back.
Hi. You think you're probably sober?
Yeah.
But you're thinking about taking the back roads home, just in case. If you're probably sober, then why would you do that? Good choice.
Probably okay isn't okay. If you see a warning sign, stop and call a cab, a car, or a friend.
That's a full glass of wine. I'll be chatting you later.
What are you looking for?
Opiates has taken everything and everyone I've ever loved away from me. Everything.
I blew my ankle out and I got prescribed pain pills by my doctor.
If making my detox public is gonna help somebody, I'm all for it. I just wish I would have had a warning.
Opioid dependence can happen after just 5 days. Know the truth, spread the truth.
Give your town a reason to celebrate, because every Goodwill item you bring home brings job training and more to your community. Goodwill, bring good home.
everybody. Welcome back to Your Need to Know. Once again, I am your host, Jody Lyons, and I am here with Dr. Sasan Hassassian, who is one of the affiliated physicians with National Spine and Pain. Welcome back.
Thank you.
So one of the things I'd like to talk about is what happens when a patient comes to you for a visit in your office, and the first thing people ask is, A, do I need a referral, quickly followed by, does my insurance pay for you? So do they need a referral, and how do you get paid?
We can see patients in a variety of ways. Most of the time, it just happens that they have referrals from their primary care physician or neurologist, neurosurgeon, orthopedic surgeon. But we see patients directly as long as their insurance does not require to go through what we call a gatekeeper,
Okay.
like a primary care physician. We have had, fortunately, happy patients who put good word of mouth, and their family members and whatnot, they self-refer. So we can see that as well. So, but most of the time it happens to be with a referral.
Okay, so now the person shows up to you. What is the first thing they need to do to be prepared to show up to you? What do you want them to have with you?
Obviously, the more organized the patient, the better in terms of having the pertinent medical information, if they had any imaging studies done, if they can give us access to the other physicians who might have seen them previously, so we can review the medical records. But if it's an acute process, just happened recently, obviously there is no workup, so we're going to start that from scratch.
Okay.
So that's why we can be in any part of the process. We can be at the very early stage of patient having an acute problem versus even late stages where it's a chronic situation and they have already seen multiple other physicians.
Okay. So it's interesting to learn about what their history is, where they've been, what medications they're taking, and my guess is they should actually have the names and contact info for the doctors they've seen.
That would be very helpful.
Okay, I mean,
Yes.
I know it seems obvious, but a lot of people forget that.
Correct. That makes a lot easier for us to obtain the information on their behalf, get the copy of their imaging, medical records, and everything else, yes.
Okay. So during the break, you were telling me a little bit about how the patient's body language can tell you a lot as well. Can you describe that a little bit to me?
I mean, that goes back to taking proper history.
Okay.
So in all fields of medicine, with pain being not an exception to the rule, physicians gather a lot of information from what patient tells them and basically their behavioral clues that they provide us.
Okay.
Now I can give you not an extreme example, but something that kind of solidifies it.
Yes.
By just using your hand to point to an area where it hurts, it gives us a clue as to what might be going on. For example, if somebody uses their finger and point to shoulder or to the chest wall and say it hurts there, a lot of times that's a localized process, more of a what we call myofascial issue, not something deeper and involved. Whereas, say, somebody having a heart attack, I mean, obviously they're not coming to see us, but to provide an example, almost never you see someone use a tip of the finger to say, my chest hurts. They use the palm of their hand, say, my chest hurts.
Interesting.
So these are some of the behavioral clues that we look for, because that by itself provides a lot of information.
So you're looking not only at the words, but at their body language and how they're behaving to give you a clue about what you're really looking at.
Absolutely.
That's excellent.
Yes.
So once you've gone through the patient history, what do you do next?
Then we do a thorough physical examination that is relevant to the area of the pain. And then that's the time I sit down with the patient and go over my thought process as to what might be the cause or what steps we need to take to figure out what the cause is. Again, it goes back to defining what pain is. Pain not as a symptom, but pain as a result of a disease process. So again, you have to think about what your diagnosis, otherwise you cannot properly treat it.
Okay.
So we go through what might be the cause of the problem. And then depending on what stage in the process we are, we talk about potential treatment options. And then treatment options could vary from very minimally invasive to non-invasive to more invasive. But again, focus for us is less invasive, the better.
Well, that's excellent, and that's something I think people need to hear. you are not automatically assuming they need major surgery. There are other things to go through first or instead of. And how long does an appointment with you usually take, or at least the initial one?
The initial appointments are set up for 30-minute slots.
Okay.
Now it could be done, you can wrap things up sooner depending on how the situation, if it's just a simple sprain, or we can use the whole time. So again, the idea is not to rush the patient to get what is needed, because it's like laying a foundation. You cannot build a house without having a proper foundation.
Right.
So that new consult visit is the foundation for us.
So it's figuring out what the issue is, starting with the patient history, and then doing a physical exam, and then you go through your brain determining what the possible causes are. And all of this is done in your office in Manassas, right?
Correct. We are in Manassas location, right at the hospital campus for Novant UVA Hospital.
Okay.
We're not affiliated with Novant, but we're on the Novant campus.
Okay. And so how often do people come back to you while you're in the process of determining what their treatment plan would be? How often would you expect to see them?
Again, depends on the underlying condition. Obviously, early on, we need to see the patient more frequently. For example, if you order an MRI study or an X-ray to review it, and then based on that, we can formulate a plan as to what needs to be implemented. Or if we decide to do some medication management, then I want to see the patient sooner to see if there was any side effect, also gauge the effectiveness of treatment. So if there is a need for modification, we can do that sooner than later.
Okay, that's wonderful. And so can you give me right now a really brief overview of the types of interventions you might have? We can go into detail on our next show.
Sure.
But I just want to hear the general options you have, because I have to tell you, I was flabbergasted when you said, well, surgery is not the first thing I look at. So what do you start with?
So again, there's a whole host of issues. And again, you have to start what area of the body. But for the sake of argument's sake, we're talking lumbar spine or the lower back.
Okay.
So depends on if it's a muscular issue or ligament problem versus arthritis in the joints versus degenerative changes in the disc.
Okay.
Versus there's narrowing in the spinal canal, we call that a stenosis, versus there is impingement of the nerve roots because, for example, a disc has herniated and putting pressure on the nerve roots. So based on that, then we can talk about either some simple injections to alleviate the tension in the muscle versus some X-ray guided or what we call fluoroscopically guided injections to decrease the inflammation around the nerve roots, or try to do some workup to figure out where the pain is coming from. Because a lot of times, these folks that come to us, the question is not, is it this or is it that? It's how much this, how much that. So just
it's
because
a
you
combination
have
of things.
arthritis in the spine
Okay.
does not mean you don't have degenerative disc disease. Or
Okay,
so
so
it's
that
like
could
a
be
car.
multiple, okay.
So just because I changed the front tire doesn't mean all of a sudden I have new tires in the back.
Okay.
So you have to look at the totality of the situation
That
and
makes
come up with
sense.
those. And then again, the whole host of other things. We can talk about regenerative interventional procedures like PRP injections. There are ablations that we can do like radiofrequency ablation. And again, all of these things do not require incision. So all of these things done either through needles or probes or no incision at all.
That's amazing. And where do you do procedures like that?
Our office, basically, I have a fluoroscopy suite in the office, so pretty much all of these things are done at our location in the office. And
That's amazing.
Most of these procedures, patients don't even need to have a driver. And once we do the procedure, they just wait for 15-20 minutes and they leave on their own.
That's amazing. And I think that's probably one of the misperceptions that you have to fight on a daily basis, which is patients are avoiding coming to you because they're afraid and because they think you're either going to make them have general anesthesia, give them surgery, knock them out, etc.
Right.
And it's not all involving hospitalization either. It can all be done, or much of it can be done in your
Absolutely,
office?
in the office. Again, the primary two reasons patients come to us or refer to us, number one is to find less invasive measures. And number two, finding ways for them to be less dependent on medication. Now, medication is appropriate for some patients, but if there is a way that you don't have to be on it and be dependent on it, that's our goal.
That's amazing. And we have about 2 minutes left, and I know that's not much time to talk about increased functionality. I know we talked about less pain makes you feel better, obviously. But can you talk to me a little bit about the psychological effects of pain and how those can get better, and the functionality of pain?
Yeah. Pain is a multifaceted problem. It affects physical issues, it can cause physiologic problems, it can cause mental problems depending on how long it's been present. It can cause depression. So the sooner we get into that situation and kind of break this vicious cycle, the better. You alluded to functional status. So it's different from everybody. So you can have an elderly who was able to only sit for 10 minutes without having pain and had to get up, but they could never sit through a movie with the grandchildren. So yes, we want to decrease the pain, but we want to increase the functional status. So that person not can sit through the whole movie, or they can go to the grocery store and not hate shopping after 5 minutes.
Exactly, exactly.
Correct.
So they could walk better, move better.
And sleep better. That's another component that people got. The pain does not in a position to wake you up all the time, because if you don't sleep properly, then you're going to pay for it later. And
Oh,
it's gonna have
absolutely.
issues.
We know the correlation between sleep and cognition, for example.
Absolutely. Correct.
That's excellent. So our real takeaway here is people should not be afraid of pain doctors. They should go to pain specialists. Like, when in doubt, go to your pain specialist is a safe bet.
The sooner we get into the process, the better options and less invasive options we can basically provide patients. And we would rather to be part of that process very early on as opposed to later.
That makes a lot of sense. And I'm really glad you're here talking about this. In our next show, we're going to talk about the different kinds of procedures you do in detail, so I hope you're prepared.
Of course.
But I really appreciate the overview you gave us about pain in general, and I have to tell you, I was just as guilty thinking pain was a symptom, not a disease, but I've learned a lot from that.
No problem.
So I really appreciate this.
Sure.
Thank you very, very much.
Thank you.
And we will see Dr. Sasan Hassassian from National Spine and Pain. You're an affiliated physician with them. And again, Manassas office, right?
Manassas office, correct.
Got that right.
Yes.
Everybody, thank you so much for joining us on Your Need to Know. Once again, I'm your host, Jody Lyons, and I appreciate your being here.